You're going to work alongside them, but do not talk to them. This was around in 400 years BC. This was around when Hippocrates and Socrates, like these guys were treating people.
If your profession isn't in a hospital, it's a little bit witchy, witchy woo-woo.
It wasn't an offence to teach chiropractic. You could teach it, but it was an offence, meaning you could get charged and jailed. We tend to focus or put importance on measurable things.
Yep.
Instead of measuring important things.
You are listening to the Movement Therapy Podcast.
Hello and welcome to another episode of the Movement Therapy Podcast. You're joined here with Andrew Darth-Weston, our Chief Educator here at Movement Therapy. He's a dual qualified chiropractor and exercise physiologist with extensive clinical experience. We really value your time here, Andrew. Thank you so much for coming and joining us on the Movement Therapy Podcast.
Thank you.
Today we're going to unpack the differences and some of the myths about physios, osteos and chiros, because we get a lot of controversial discussions around those three professions. We're going to talk about why we have them here at Movement Therapy and why we all work closely together. And obviously, breaking down some of the walls between all three of the professions. So without further ado, Duff, I want to talk about where they came from. So what the origin of them first, which one came first, how did they all start and how did they split?
Yeah, we've talked a lot. The fact that there is a wall between them, there is controversy between them is a bit silly.
Yep.
It's like the analogy that people building a house, there's a builder, a plumber, electrician, there's no wall between them. They're all part of building a house. We should all be one team helping a patient. Obviously, we might have different theories or histories to what we do, and maybe there's differences in technique. But at the end of the day, we're all here to help the patient or the client. The fact that we're arguing over or having a turf war over treating someone based off how we look at the body is pretty silly. We all go to uni, we all learn anatomy, physiology, neurology, and rehabilitation. I don't know why we have this turf war, but
is that hierarchy, right?
Yeah.
One's better than the other and one's more legitimate.
And I think we've created this ourselves.
Yeah.
I see a lot of patients, I'm sure you do, where people come in and physios treat muscles and chiros treat bones. And if that was the case, then I would have to take all your muscles and skin off and just treat the bones. It's pretty silly, the fact that we're arguing about this, but it is what it is.
Yeah.
And a lot of this comes down to the history of it. Speaking of the history of it, this is nothing new. There's been manual therapy or manipulative therapy, whether you call it adjusting or manipulating or mobilization or bone setting or
and I guess that's the cracking version of what we say.
Yeah.
So
and this was around in 400 years BC. This was around when Hippocrates and Socrates, these guys were treating people, and they used manual therapy to heal, treat the body. So this is nothing new. So for hundreds of thousands of years, people have been using different forms of manual therapy. Probably chiropractic gets the raw end of the stick because you see lots of emotional baggage that comes with what is manipulation.
Sure.
So anyway, it's long standing. It was probably first, as we know it now, first popularized by the first osteopath who started it, Andrew Still. He was a medical doctor, so he came from training thinking, I want to look at the body more than just pharmaceuticals, from medications, from things like bloodletting to get rid of disease. He wanted to look at more of a manual approach, more of a biopsychosocial approach. Yeah. He was the one that's probably popularized it back then, which is now a normal part of how we look at the body and look at healthcare.
That biopsychosocial is kind of just everything.
Everything.
Yeah.
How you interact with the world, how your thoughts, how does your brain function, the food you eat, the people you interact with, your values. What do you see as your problem? How is pain affecting you? All these things is part of this biopsychosocial approach. He was saying that back then and was considered a little bit of a weirdo, which is funny because we've come full circle. And now that if you don't think like that, it's like now you should be shunned.
Yeah.
So he treated like that. He used manual therapy. Him and a lot of osteopaths learnt a lot of great techniques. That was one side of the coin in terms of manual therapy, the new school way of thinking about it, still in the early or late 1800s, early 1900s. So that's the osteopathy world. They went very global in their approach, which again is hard to rationalize.
Yeah.
I had a really good quote from the Mops and Moes podcast, so shout out to them.
Yeah.
We tend to focus or put importance on measurable things.
Yep.
instead of measuring important things.
Oh,
Yeah. So if you think about it like that, right? Like,
geez, that gave me goosebumps.
well, so yeah, I heard that. I went, that's brilliant. Because in the world of what we do, you could get someone's knee and go, oh, they're 10 degrees short. I need to improve it.
Yeah.
That's something measurable. But how important is that in the big scheme of things? It's like, I just need your knee to work better.
Yeah.
In our world now, it's very minutiae, very focused on that 10 degrees. And we forget the big picture of let's improve the important thing here. Like the person needs to move. They need to go for a walk.
They need to walk upstairs. They need to get out of bed.
10,000 steps. They need to have good relationships. They need to go to be able to work and provide for their family. But, that 10 degrees, I've got to focus on that.
Yeah.
So he was on that important things, but hard to measure.
Yeah.
So when it's hard to measure, medicine goes, oh, I don't know. I don't agree with that. So that's where you could argue a lot of physiotherapy came out of that. Like, let's make things more measurable.
Yeah. But
that's one side. You got osteopathy, then you got chiropractic. Chiropractic was first coined or first started by D.D. Palmer, a guy that sort of had worked up through different phases of like medicine, but was on the outskirts of medicine.
Yeah.
He was by no means a doctor or anything like that, but he'd been involved with health. Anyway, he's started his chiropractic world by treating this guy, Harvey Lillard's upper back. So he first adjusted or manipulated this guy's neck, and he cured his deafness. And so we don't know how deaf this guy was. We don't know to what degree. Again, it wasn't measurable.
Yeah.
But what Palmer thought is that he adjusted the guy's neck and he's changed something.
Yeah.
So you go along a bit of time later, he then also had a guy that had a heart condition and had symptoms from this heart condition. So we know that is viscerosomatic.
Yeah. So pain that's referred from the organs into
the body. Yeah, into the somatic system, the movement system. So he's adjusted this guy, and now this guy's symptoms got better.
Yeah.
And so Palmer's going, oh, there's something here. He rationalized that he treated or he reduced nerve impingement, which is that classic chiropractic take pressure off a nerve.
Yeah.
So that's what that. He treated a guy named Reverend Samuel H. Reed. And this Reed, suggested that you're treating via your hands, and they use Greek words, chi and praxis, which is meaning by hand and the practice of. So done by hand. That's what the word chiropractic means. So that's where
it's got nothing to do with bones.
Nothing to do with bones. Nothing to do with joints.
Yeah.
It's done by hand.
Just done by hand.
Yeah. Which classically, this is kind of where love it or hate it, cause, benefit, and negativity is where chiros have really just stayed.
Yeah.
We do it by our hands, and maybe there's the lack of wanting to implement other things. We can get into that.
Yeah.
But yeah, so now we're into the late 1800s. He started a chiropractic school because he'd almost died. He wanted to teach this stuff after practicing sort of secretly for a couple of years. So he started having students. In his first 15 group of graduates, 5 of them were MDs, which I think is important to note because as chiropractic went on, there's a rough history of medicine versus chiros.
Yeah. They seem to be very different.
Very split. And there's a big reason why.
Yeah.
Well, as far as I've been told. But yeah, the first few were actual MDs, and they wanted to learn more about manually treating the body.
Yeah.
So then you had a whole bunch of schools. Then in the early 1900s, something changed. Medicine started noticing chiros. And at that point, it became clear that, well, these guys, and they don't have a medical license, but they're treating people. And that put a bit of alarm bells up. And so at that point, it wasn't an offense to teach chiropractic. You could teach it, but it was an offense, meaning you could get charged and jailed, and people were. So D.D. Palmer was jailed. A few other people were jailed for practicing medicine without a license.
Wow.
So that was the first.
So they classed it as medicine. That's
the thing. It's like, I don't know if chiropractors would have said, oh, we're doing medicine, but they were treating people.
Yeah.
And maybe they said more than what they should have, like meaning we're treating disease or we don't know.
Yeah.
But it raised suspicions or concerns. So you had some MDs that were interested in it, but if they got involved, they were like shunned. They weren't allowed to practice in hospitals anymore.
Right.
They were threatened their license was going to be taken away from them.
Yeah.
So if now you're an MD and you're like, I like this chiro over here and they're doing cool things, but I'm not allowed to hang out with that guy because I'm going to lose my license, you would start to go, sorry, I'm not involved with you.
Right.
And that happened. So, so medicine, around 1910. Then you had the first ever chiropractic paper was by Sharla in 1911. And it was actually very favorable of chiropractic. Like it was, this is a good thing. You know, they're treating people. Great. But that in about the mid 1920s to 1950s, you had a guy named Morris Fishbane, and he set off a full on malice campaign of 50 years of just running chiros into the ground.
Who was he?
He was an MD.
Just a doctor.
Yeah. He went global. If they had podcasts, you'd be on it.
He on everyone.
He was very smart. He went to public papers. He went to radio. He used people.
Yeah.
He went out and he said, he was quoted as saying chiros were an unscientific cult. Chiros were either bumbling incompetents or greedy quacks preying on gullible citizens.
I think you said that this morning.
Yeah.
Oh, don't throw me under the bus.
He used phrases, rabid dogs, they're playful and cute, but they're killers. So this is
unreal.
AMA, had this as their documentation.
So this is early 1900s.
At this point, this is like 1920s and 1950s.
Wow.
So if you're a doctor hearing this stuff, you're like, I'm not going near this.
100%.
People, right?
Yeah. This is the split. That's where it started. The animosity, the split, the sort of divergence.
Yeah. As far as we know, this is where it looks like, okay, medicine is we're not dealing with you guys anymore. There were still people that were wanting to be a part of it.
Yeah.
And one guy was Wilk. So they had a court case, and it was approved, that in 1981, a physician may, without fear of discipline or sanctioned by the American Medical Association, they may refer a patient to a duly licensed chiropractor when he believes that referral may benefit the patient. So at that point, if you're a doctor, you were shunned to refer.
Yeah.
Now that court case said, no, you're allowed to do it now, and you will not be prosecuted as a medical doctor.
Yeah.
So that would produce a lot of fear going, I'm not going to send a patient to that guy,
absolutely.
that girl over there, because I'm going to get in trouble.
Yeah.
So that would have created a lot of issues.
And there was still this public.
This is in the public. This is in papers.
Yeah.
This is on radio. What was really interesting is that a lot of the suggestion that chiro was their success was due to psychological suggestions or the body's natural recuperative powers, which now that's exactly what we're told. That's what's happening. It's like, the patient needs to believe, they need to have the biopsychosocial model. They need to understand that there are things happening, but it's your body that's going to heal it. It's like, so they were right. I just think this is funny that we're having this conversation because this model of like, oh, well, healthcare is what we do to you. But in the end, it's no, your body needs to heal it, and you have to have a belief that this will help. But it's not just voodoo crackery.
Yeah.
But anyway, it was interesting. So there were MDs who were interested in chiropractic, but they were shunned, as I said. They were going to lose hospital privileges if they were referring or working with them. So, like in 1972, the AMA wanted to eliminate chiros. They went to court and said, we're going to get rid of their licensure. They lost. And there was a court case again in 1981. And
it's pretty recent.
This is not that long ago.
No.
But the AMA were found guilty of an illegal conspiracy.
Wow.
So you can think then, you're like, okay, there's a big court case here, and this is just before I'm born, right?
Yeah.
So you still got chiros that were pretty much either about to be put in jail or medical association going, we don't like you. But at the same time, there was a big, obviously some dodgy things going on. The chiros essentially won it. In the American Hospital Association settled in the middle of the trial, allowing chiropractors access to hospital services. So I don't know where that's at now because this is in America at that point. In New Zealand, roughly the same time, chiropractors were the only professionals by virtue of their training to be able to determine the need for chiropractic treatment. So no one else could determine that for them. So that really gave chiros their own self-governance of, I'm going to provide treatment based off what I think, rather than I have to rely on a doctor to tell me what to do.
But that would rely on people coming to seek your services out.
Yeah, and people were people were shunned to do so.
Yeah, they were scared.
And that's when chiros were recommended into Medicare. So that was in New Zealand in 1979.
Wow.
Then we had an inclusion into Australia. So we had osteopathy and chiropractic as essentially one teaching tool. Yep. So when chiros and osteos were trained in early 1950s, 1960s, 70s, they were given both osteo and chiro in Australia. Then that college became Sydney College of Chiropractic. It became Macquarie University where I was trained, and now it's a master's degree with the same level of education as everyone else, but it didn't start off like that.
Nah.
Chiro has two really distinct schools of thought at the moment. You got your traditional people, the straights, which is the old school DD Palmer way.
Yeah.
And then you got the mixers, which I'd put my camp in, like the.
Sounds like an episode of West Side Story.
Right.
You got your gangs.
This is what's probably holding us back. As
Yeah,
a profession. Sure. You've got two camps fighting for the same ownership of a title.
Yeah.
Physio kind of has some, like this is sports physiotherapy versus like, old school physiotherapy where you do this and that and like probably just nowhere to the same degree. Osteo's just really held its own for a long time. It comes in and out of flavor with medicine based on your hot topic. Chiro's kind of always got this negative flavor in medicine in the media.
Yeah.
It's an easy target. It's an emotional word for people to hang their hats on previous history.
Yeah.
And you can see the rough history that's gone against medicine. Yeah. So again, chiros probably want to hold on to this word adjustment.
Yeah.
They want to own that treatment, but there's lots of osteos. There's lots of physios. There's medical doctors that adjust people and manipulate. So no one owns that. And that's, created controversy. And it's one form of treatment.
Yeah.
Just like a builder has a drop saw and a hammer.
Yeah.
It's like it's the right tool for the right job.
Yeah.
But chiros have really put their hands on just that one tool. And that sells us short because we have the same, if not more level of ability to assess, treat.
Yeah. And I think people get so passionate about hating chiros with no, I guess, knowledge of where they came from, what they actually are, because they hear about the potential of, danger with cracking. And we'll talk about all of that and the common myths and things. But that's the fear around it. And they get so passionate about hating it that they just don't even bother sort of looking into it.
I mean, that's partly why I went and studied it. I started off as an exercise physiologist and still am.
Yeah.
But I would work with other professionals. I'd work with doctors. I would treat doctors myself. And I'd say, it'd be good if you had this and this sort of treatment done, a manual therapy approach to collaborate with the exercises I'm giving. Or, you know what, your spine has a big scoliosis and it'd actually be really good if you had this sort of manual therapy approach to help. And the doctors are, okay, what are you suggesting? And I'd say, well, you could try this chiropractor. They go, no. And it was a flat out no. I go, why not? And there'd be like crickets.
Yeah.
I'm like, so there's no answer.
There's no reason.
Well, there's no reason. Like, why not? And there was obviously a fear from them. But there was no answer as to why not. And I was always intrigued by that because I'd been told, they're a bunch of quacks.
Yeah.
Don't see those people. And yet I'd started working with a lot of them and they're doing a lot of courses or using a lot of rehab tools that I was very interested in.
Yeah.
And you know what I'm like? I want to go and study all these things. So I was interested in all these things. I go, why do chiros keep going to these different types of treatment tools? Like, why are they so interested, but other professions aren't? And so I kept going down this rabbit hole of like, these chiros seem cool in that they've got this ability to do this really powerful treatment, but they're really hated by a bunch of people, but they're actually doing really cool things. So I wasn't tied up in all the negativity of it. But I wanted to study a few things. So one being a few of the courses that we do here, obviously DNS, which was introduced to Australia by chiros. It's run by physios in the Prague school in Europe. And I wanted to do FMS and SFMA, the type of models that we use here. And again, high up in the food chain there's a lot of chiros doing it. I'm like, why are this profession that seem to know nothing? They actually do a lot of good stuff. So I went and studied it. At that time, I could have done physio, osteo, or chiro. Osteo was hard to do around here. You had to move interstate. Physio and chiro are going to be the same amount of time. I liked the idea of these guys learning what other people, are treating or teaching. Yeah. So I wanted to learn those things. And I wanted that skill set that a chiro gets. And I work with people that are like, well, you do this and then I'll teach you the rest. I was like, no, I want to go learn this the full way. So that's why I went and then studied chiro.
It's funny that you say, like, you were taught that. When we were taught at uni, and I don't know if I was taught this, but I was always thought that chiro wasn't a uni degree. It wasn't respected. It wasn't. So if you wanted to do health, it was doctor, podiatry, physio, OT, like these allied health professions. Chiro wasn't mentioned at all. It wasn't even part of it. Same with osteo. Yeah. It wasn't close.
I mean, my first few years of practice, I had patients go, "Oh, did you go to uni?"
Yeah.
I was like, "Oh." They thought it was like a TAFE sort of thing, and nothing against TAFE, that's fine.
No, of course.
But they didn't know that there was this master's level program.
Yeah.
That the quality of education, like I would love someone to, if they're fearful of this or or not knowing, like go and get the syllabus from the 3 different degrees and look at what the chiros learn. You go, ooh, there's actually a fair bit these guys learn.
It's crossover.
The level of education is really, really high, particularly in Australia. And it's sad that they're considered this uneducated, just going to hack your spine type thing. So, I know people who went to uni in physio who were told, do not work with chiropractors. And this is early 2000s, right? Like,
100%.
right. So you just think that's not fair for a person who's in a position of power in an educational format to tell 100, 200 students, don't see this profession.
Yeah.
You're going to work alongside them, but do not talk to them.
Yeah.
Because that's what happened back in the history of it.
Yeah.
And so that sets a big tone for a new grad physio coming out going, I've been told not to work with these people. They're a bunch of crackpots. But then again, a patient might walk off the street and go, well, I saw this chiro and I had this done. Can you do it for me too?
Yeah.
And they're automatically going to put a negativity on that patient and go, well, no, you shouldn't see a chiro. So that's hard. And that creates a turf war because we're like, in the end, they're fighting over this patient. There's plenty of patients to go around. We don't need to be fighting. We need to be working together. Like it's dumb like we do here. We work together to the sole purpose of improving someone's health. So that's sad that that's like that. Yeah.
Literally in the same breath, I had a rheumatologist last year tell one of my patients who I referred to them that physio was useless. Don't bother going back. You're not doing anything.
Yeah, it's the same thing.
This is a patient I treated for over a year. And now there's this negative connotation of someone who they think is a hierarchy above me has told them that my profession is useless. Like, and I was having to sort of justify my position and my practice. And it's hard.
Well, it's sad because that patient walks away going, well, I've invested my health into this person.
Have I wasted my money, wasted my time?
And now I've been told, then, this is useless. So now they're going back second guessing, well, who do I believe? Do I believe Ethan or do I believe this rheumatologist? And even if I don't believe either of them, they've still got this, this profession's fighting over my health. Where do I go?
Which one's right?
Like that's sucks. Like we should be there working together, not against one another.
Yeah, 100%.
Yeah.
Zoe, from your perspective, I'm very keen to get your thoughts on this.
Yeah.
I know we're jumping around, but from
we're jumping around heaps.
from a member of the public who's not a health professional, what was your opinion of chiros? Where did you sort of sit with that?
Yeah, look, I am someone who has been around physios in both professional and personal aspects for a long time in the past. But before coming to work at Movement Therapy, I hadn't had a lot to do with chiros, and I was very, the similar way of, I hate to say this in front of you, Darcy, but
I
think
it's great.
But I had been told, and I'm studying a health degree myself in a bit more of the background, not the hands-on, more of a policy way. It's always been, if your profession isn't in a hospital, it's a little bit witchy woo-woo. Yeah. And I think also, I guess, as someone who, I'm on the internet a lot, you go on and you see a baby getting adjusted or a cat getting adjusted.
Or a story of spinal injury.
Yeah, people, it's always, you always see the negative thing because the negative will gain a lot more traction than the positive. So, I think working at Movement Therapy has definitely helped me not think that you're out here practicing your witchcraft, which, I don't know. It's very interesting because it's something that I've always, gone, you go to a chiro and you get your back cracked, and does it really do anything? No. Because I guess I've been around physios and knowing physios and talking to them a lot. It's always been that, it's a little bit, it's, I guess, outcast in a way, but it's very important, I think, and it's really good to be able to see how you can all interconnect.
Yeah. And that's, again, back when medicine was really changing things, like as Peter T would say, going from medicine 1.0 to 2.0, they had really, really sharply changed things, meaning for a bad migraine that was not treatable, let's not cut their head open anymore. Let's give them medication. At the same time, chiros were treating spines with their hands. At that point, medicine said, join us or you're against us. And chiros were, well, we're not doing what you're doing. We're not part of this pharmaceutical model. We're not part of injecting. We're not part of treating medications. That's not how we're taught. So we're going to keep doing what we do by hand. Now that's limited it to, well, now we just treat by hand, as in chiropractic. So at that point you go, well, if they only limit themselves to the adjustment, it is falling short. It is not treating the whole person. It's just treating one aspect. So a chiro that only adjusts and that's it, there's a lot of things that are left on the table, literally.
Very good.
Excuse the pun. Versus a chiro that now goes, hey, I've assessed your whole body. Yes, I can use this one tool and I can manipulate something to improve function. It is the most powerful, fast acting tool that we know that you can use on the body. And in terms of safety, it's actually very, very safe, but it's very easy to grab a screen grab of a media thing where it's like, oh, this chiro did this. And that's, it brings a lot of emotion.
Yeah. I think with like the Western medicine and that sort of thing, even still the holistic approach, it's not always accepted, and chiro kind of gets put with your naturopaths and that sort of thing because they are historically not as accepted. And then I guess people just kind of look at a chiro and group them in that same kind of non-traditional
which I'm okay with. Like, I don't, people will say it's conservative and it's, like non-medicinal and those sorts of things. It doesn't bother me, except for when it comes to public health and public law, when things get then shunned because it's been put in a category. That's where it becomes a problem. And again, then that turf will comes up out again. When chiro was first done, they were put in as an institute. So in British, it was the Institute of Naturopathy, Osteopathy and Chiropractic. So they're all lumped together. The funny thing is osteopathy came from medical doctors. I just think,
the irony of them now hating, like, it's a profession. You started it.
It was started from a medical doctor.
Yeah.
I just think it's so silly. But when people understand the history a little bit, you go, oh yeah, this is a dumb turf war.
Yeah.
In Australia, we're very strict with certain regulations and codes and healthcare, which we should be. In other countries, they're still strict, but chiropractors are one of the lead therapists in a hospital setting. So it's almost like we're blinded here to go, well, this is what happens in Australia, and if it doesn't happen this way, they're on the outer.
Yeah.
Same in the sporting field. You know, like traditionally, like chiros weren't allowed to be on the sporting field. That's changed dramatically in the last few years. It's still not the level of what a physio is, but
so when you say they're in hospitals, is that Europe and America?
Yeah, like thing? Germany, like chiros are highly respected as an in-hospital care system.
Yeah.
Sweden, they are prolific in the way they treat in hospitals.
We should look at their government expenditure on low back pain.
Yeah.
And see if there's a difference.
And so that's the problem, right? Like we think, like Australia's really small in how we're looking at health, but I still see that we're on the outer, and I think there's probably some chiros that really like that. And it's just like, they're just going to sit their little pocket. I don't want to be part of medicine. I don't want to be part of the hospital. I just want to treat my patients and that's it. And then there are others that go, no, we want to be on the same level playing field as everyone else. So there are people fighting that. At the end of the day, you've still got these mixers versus straights in the top field of chiro. And I don't know whether that's doing us harm or good. It's definitely potentially, from what you read out there, it's potentially holding us back in terms of growing the profession, because you've got two of our big dogs, mum and dad, fighting over what should we run as.
Yeah.
That would be like a mum and dad in a family saying, well, I want to treat our kids this way and I want to treat this way. Like we've still got that going on.
Yeah.
So that's, it's probably not helping us move forward.
So to recap the history side, you got osteo came first from the medical profession. So obviously doctors, osteo, chiro became after that.
Yeah.
Physio, where does that sit in this?
Really popularized post-war.
Yeah. And
people being injured. The first kind of main physio guy was a Swedish gymnastics coach, Henrik Ling. So he was the founder of the Royal Central Institute of Gymnastics. And he, like, if you look at the old photos, they're amazing. There's old big gymnasiums with like gymnastics style gym.
Yeah.
Parallel bars and rings and, all those sorts of apparatuses.
Yeah.
And he kind of popularized physio as a way of treating then, but it quickly turned into really nurses in war and post-war treating people. And so kind of nurses became this manual therapy, providing physical therapy to someone. And so there became that whole physical therapy of war injured people, trying to get them back to function.
Yeah.
And there was a lot of people in war, obviously.
Yeah.
A lot of injured vets. So that started the mainstream physical therapy.
Mm.
I don't
Talking
know.
like World Wars 1 and 2 and that sort of region.
World War I. Yeah. So the physical therapist got recognition in 1887.
Mm.
So like it's not that different to really the whole time of osteochiro.
Yeah. So it started in Sweden, or did it start?
Yeah, that's kind of the main. If you were to go and look at it, that's the kind of here's the main part of physio. But at the same time, it was being practiced around the world via nurses treating. Yeah. They just weren't at that point classically called a physical therapist.
Yeah.
I don't know where it became, like other parts of the world call it a physical therapist.
Yeah.
We call it a physiotherapist. Yeah. I don't know where that changed.
Yeah. Yeah.
And we, like, people say, oh, when you go to Australia, it's a physiotherapist.
Yeah. Yeah.
Okay.
Yeah. Because Americans definitely physical therapist. I don't know what it is in Europe, but
physical therapist as far as I know.
Yeah. Sure. Yeah.
I think Britain does similar to what we say, physio.
Yeah.
But yeah, we're all providing physical modalities,
yeah.
physical care to someone,
yeah.
using our hands, using our bodies to help someone be more physical, be more healthy that way.
I guess in terms of the stereotypes currently then, that sort of fits this model of going, okay, well, physios now focus on, you know, potential like exercises and movements and the physicality of it. Yeah. Osteos are thought of more of the holistic, you know, general profession of the body. Yeah. And then chiros are your back doctors. Backcrackers. So that's where the stereotype I think fits and falls into.
Yeah.
Let's get to breaking some of those down. Yeah. Specifically for chiro. When we talk about cracking.
Yep.
What is that? What are we actually doing? Why are you doing it?
Yeah, I think the first part there is cracking sounds like something's been broken.
Yep.
So we've got to throw that.
That's why the term adjustment's coming.
But there is a noise.
Yep.
That cracking noise is...
that was Darth just cracking his nut.
That was...
If everyone's not watching.
It's a nitrogen bubble
that
is created due to pressure within a joint. So it's a joint that's being stressed, meaning it's being stretched to a degree where this fluid inside the bubble, this synovial fluid inside a joint, is being stretched to a certain degree. And at past a threshold, and it's different for different joints, how big the joint is, how much fluid's in it. An arthritic joint has less fluid, so it cracks differently compared to a young joint. But this level of fluid that's being moved or stretched gets to a point where that fluid becomes a gas bubble at some point in the fluid part. And that gas bubble is nitrogen. And that gas bubble reaches a certain threshold of stress to a point where it goes pop.
Yeah.
That pop is called a cavitation, just like if you got a propeller and moved it through water. As that propeller hits through water, it creates a pressure like change along the sides of the propeller and a gas bubble forms. And that's also called a cavitation. So the engineers out there would...
They'd be rubbing their hands. Yeah. But I've never thought about that actually. A propeller underwater creating bubbles.
Yes.
Not from catching air and pulling it down, but the speed of it and that's stretching.
That's important. The speed, because the speed changes that fluid dynamics within a joint faster than what the patient or the client, except in like that scenario, can actually then deliberately, voluntarily change what you're doing.
Yeah.
That's what makes it look violent.
Yeah.
The word for that is a HVLA or high velocity, low amplitude. Yeah. And it's the adjustment should be that. And that would be the difference between adjustment and a mobilization, where mobilization, and we learn this here at therapy, where there are different grades. And that's thanks to a famous physiotherapy called, Mulligan, his last name. But, grade 5, a HVLA, it's high velocity, meaning it has to be fast because it has to trip or take the joint through its stress point before the body has a chance to react. Yep. And that's probably where people get the fear from. Meaning this thing is
a really sudden
movement, but it's very, very short.
Yeah.
Low amplitude.
Low amplitude.
So it's actually taking a joint way less range of motion than if someone was to go and gradually move the joint.
Yeah. So these mobilizations, we're saying that's a very physio model. And that's what we're sort of taught, of taking a joint and moving it throughout its full range of motion, depending on what grade you're doing,
which is great.
Slowly.
Yeah.
Which is useful in some instances.
Yeah.
And you're saying that high velocity is taking it to its end point and then forcing it into.
So, be more specific, it's not taking it to its endpoint. It will take it to a joint lock, which doesn't necessarily mean endpoint.
The endpoint of its movement, it's
because you can take the joint in 3 different planes of motion and lock it, but with nowhere near a certain end range. So as chiros, we taught one of the riskier things, and this is not just for chiro, this is for hairdressers. This is for anyone who puts their neck in a sustained position, because there are lots of people who have a VBI, meaning a stroke caused from a condition in their neck that's let off a very pathological process to the brain. People have had it sitting in their hair basin and they occlude off their neck and then they cause a stroke to their brain. That's anyone treating necks. So this is not just chiros. This is chiropractors, osteopathy, physiotherapy, physical therapy. This is even massage therapists have to be aware of this, that is a possibility when we're dealing with someone who potentially has a threat in their neck. What we know in history studying this, that statistically one of the people that have these issues are going to therapy, whether they're going to an osteo or a chiro or a doctor, they're in the process of that happening. And so they have symptoms. They have that viscerosomatic symptom again. And then the therapist needs to be able to do a good assessment, and it doesn't matter what therapist you are, and go, this is something that's pathology. I don't want to do anything to force this. I need you to go to hospital and get something done here. But where it sort of gets back to that manipulation, that joint is taken up in different planes of motion to be able to create a lock, meaning the joint is now at a point where it can then be manipulated or mobilized. At that point, the joint is tripped or facilitated or stretched, whatever word you want to use. And that causes that nitrogen bubble to be stressed again and pop. At that point, you're taking a joint in its normal range and you're going through what's called a paraphysiological range, which something people won't normally do unless it's done fast, or whether it's done to them out of control, and then they go beyond to a pathological point in their neck. So that would be someone who goes into a football tackle, their head gets taken, and they get stretched beyond that range because they haven't done it. It's done passively to them, and it takes their neck into a range that would be considered a pathological range, and some structure is going to have damage to it. Same thing as a whiplash. What the chiro is trained to do, or an osteo, physio is not, unless they go and do further training, which again is now another silly thing. It's just like chiros are getting in trouble for manipulating, but then a physio can go and get that same level of training, and now they're not in trouble. Anyway,
but we're physios.
So this is, I think chiros don't like us, is they want to own it. They're like, that's our tool.
Sure.
It's like no one owns it. We're all allowed to treat, but you're not allowed. No one is allowed to go and manipulate someone's neck. Like, it's actually an offense to go and do that unless you're trained. So the only people that can do it off the bat are chiros, osteos, and medical doctors are allowed to do it. You're allowed to do it. And it's been done with no training, but it's been done. And then a physio is allowed to do it if they go do extra training.
Of course.
And at that point, if someone else goes and does it to someone, it's actually illegal. You're not actually allowed to do it because of the potential effects.
So I guess the main point with that adjusting is that you're not taking your joint to its end point and then pushing it. You're winding the joint up enough to create a lock of a particular bone on bone, or joint, and then you're tripping that joint into some form of position. A
paraphysiological space, meaning the joint is still in a safe place, but it doesn't normally go there, hence why you have those big stretch phenomenon happening. Look, there are times when people do get locked and they go to end range, and in a grade 4 mobilization, you would be going to that end range. And there are some manipulation techniques that are going to full range. The way I was taught, we're doing our utmost to avoid end range locks without having multiple planes of motion to take up safety and comfort. Like no one wants to be treated that it hurts.
And a full end of range motion is a really aggressive position. And that's, I guess, the safety of the adjustment is that if you don't take a joint to end range, then you are in such a safe position that the joint has so much more access to movement, then you're actually fine.
I think where it creates both love and hate on social media or TikTok or whatever, it looks very fast. Because it is. It is fast, and it should be fast because it's safer. It means there's less force needed because it's high velocity, low amplitude, meaning it's a huge amount of speed, whatever the technique is, with very, very low amplitude meaning very low depth into a joint.
Yeah.
And very low force.
Yeah. So it's safe, but it looks incredibly unsafe, I guess.
Yeah.
And sounds unsafe.
Yeah. If you don't have that background information on what's being done and why it's being done and how as well. If you look at it and you're just scrolling and you see someone getting twisted around or a big noise and the reaction to it as well, you might go, ooh.
It is funny too because hearing it just live and the manipulative noise versus when you put a microphone on it, and I've played with it. I've been at courses and we were teaching like with a microphone and someone did it. It's like, and you play it back, whoa, that sounds very, very different.
Mm.
Yeah.
So when that comes through someone's phone on TikTok, you're like, okay, that's not what it sounds like in a room, but that's very, very addictive for some people and very, very off-putting for others.
Yeah.
That whole ASMR thing, where patients come in and they just want what they see on TikTok. I'm like, TikTok. And I sit there and go, that's not healthcare. I'm not just doing something because some other person. Yeah.
What actually happens? Like, why would you use that technique? Obviously, case by case, it's different. Naturally. But what are you trying to achieve physiologically out of that crack?
Yeah. So, this will be something that we will probably never know 110% every time, but there's been lots of research on it. There has been lots of, research that then finds the previous research positive and then both, repeatable. So we go, okay, that's good research.
Yeah.
We can never be 100% accurate. That is, it's exactly happening where we think it's happening.
Yeah.
That's just like everything in the body. Like you go to a doctor and they do a cortisone injection under a guidance and sometimes it still doesn't even go where you think it goes.
Yeah.
So to put that aside, what we think to the best of our knowledge, we know happening is that the joint is moving through a space that is controlled by the both soft tissues, the active tissues, meaning the muscles, but also the ligamentous, the joint capsule, the fascia around it, that is all being put under stretch.
Yeah.
So when you put something under stretch, we have these little nerve endings in our bodies called receptors, and the predominant one that we're talking here is mechanoreceptors, meaning they feel something is happening. We're not really aware of that happening.
Yeah.
If we were, we would drive ourselves bonkers because my brain would be telling me, get off your ass right now. You are squishing me all the time. So
compression, stretch, and
So that's how our body works the whole time. We have these little mechanoreceptors in all our joints, our connective tissues. And so when that connective tissue or the joint is stretched, the body has a signal that goes up the spinal cord where it's coming from. And that's sending messages to the brain. The brain is then sending inhibitory messages back down. And then you've got local mechanical nerve endings and tissues that are going, okay, I'm being stretched. And because it's fast, the nerve endings sometimes, the nerve endings are getting challenged quicker than what you can voluntarily do, unless you do voluntarily do it. That's when someone can actually get, one, the treatment doesn't work. Two, they might get hurt. So if someone fights you, the therapist should go, no, don't do that, because they're undoing what that mechanical reception should do. So the person is actually fighting the natural intent of the treatment. And that's not a good time to then force. That's the wrong treatment. But you are now creating a reset or a immediate relaxation due to the stretch. And that then creates a phenomenon where the nerve again resets. And the easiest analogy would be if your phone's doing something weird, you turn it off and you turn it on and it comes back online and you go, it's working again. Fortunately for us, when that happens in our nervous system, you get this reset, you get this new threshold of those nerves at a firing point. So that new firing should be, and most of the time it is, a newfound, the body's in a more happier functional state. That's not 100% of the time, but that's the idea being you've now challenged the mechanoreception around the joint. This then gets into the whole burn out of place model in chiros, where there's a naughty word called subluxation. And that was when, back to D.D. Palmer, they were putting a bone back in. That subluxation is now like, if we think about it medically, it's like, well, there's a bone's dislocated. Out of joint. The chiro word for a bone that they could feel was called a subluxed bone.
Right.
And it was used all around the world. It was used in other, not just chiropractic, but chiros really took on a hold of that word. And we're like, I'm putting that bone in place. And I'll still have patients now go, oh, did you put it back?
Can you put it back?
We know that doesn't exist.
Yeah.
But we also know that there is some truth to it.
Yeah.
So meaning, what do they say about, the conspiracy theories that there's some percentage of truth in them?
Yeah.
We will feel a joint has either inflammation in it or it has tension around it. And then that changes the natural, resting position of that joint. Doesn't mean it's out of place.
Yeah.
But it's natural.
Or you've picked it up and put it over here.
Exactly.
It's just changed its position.
Yeah.
Essentially.
Like the joke in the chiro world is like, oh, my back's out.
Yeah.
Like, oh, where did it go?
Yeah. But you hear it all the time. I'm out of alignment.
Yes.
I hate people coming in. Can you fix my pelvis? It's out of alignment.
Yeah.
Like, I don't even know what that means.
But there is some truth to it that way. If you feel them, you're like, oh yeah, your pelvis is twisted. Like, what is going on here?
Yeah.
And that's that resting tone of the threshold of those mechanoreceptors, those nerve endings, has told your muscles to hold some sort of contraction.
Yeah.
Those muscles, whether it's, the hip flexors are then aggravated to be on and hold the pelvis there in a hypertonic state. Like then the joke is the person goes, oh, my glutes are weak because I go, well, why is that? And they go, well, my hip flexors are tight. I go, well, why is that? Well, because my glutes are weak. And I'm like, which one is it? It's like, they're both.
Yes.
Because they've got messages coming from that spine saying, I need you to stabilize me more. One side is doing it more than the other because of that mechanoreception. So the body is doing its utmost to keep our eyes parallel with the ground and keep us upright.
Yeah.
So the nervous system is constantly sending those messages out via those little nerve endings to say, hey, do your job and hold me up. Even if your back has got tension on it. And now
in one direction and not the other direction.
Yeah. And we're not symmetrical beings perfectly. So there's always going to be something. You've got hand dominance, like someone's going to lean. Yeah. So there will be this, tension that's put on because the nervous system is telling it. And chiros have really gone to the nervous system. Like their model is very holistic in nervous function. Where osteo might go, oh, okay, well, there's also the vasculature. And it's funny because both of them run together.
Yeah.
Like the nerves supply the vasculature and the vasculature supplies the nerves.
Yeah.
So they run together. Yeah, I know it's silly too.
So the alignment phase and I get frustrated or twitchy when chiros start taking back x-rays and going, oh, your T3 is rotated 2.3 degrees to the right.
Yeah.
Is there solace in that is a legitimate type of assessment that we need? Or is that sort of going too far into the whole, no, I'm just the back doctor and I crack the back into place?
Yeah, it's an interesting because as chiros, we get a external license to take x-rays. And so when I went through, we were still given an x-ray license and there's only us and radiologists who could do that, radiographers. So at that point, through that school of chiropractors going through, they started using x-rays to prove what they would feel.
Right.
And it was kind of revolutionary in terms of, oh, look at this. We can actually use this to look at the spine inside. But it's an early model that people have kept where we know now that model is adapted and, we know that it's not just a bone out of place. And there's many reasons why a bone could be. I think one thing that I'll talk about now that's very still controversial for people and they sit there going, nah, but that bone could be sort of shifted or meaning pulled to tension by the viscera.
Yeah.
So you could have a internal issue that is literally pulling your spine inward because how much inflammation and swelling is going on internally versus someone who just sits and hunches their back the other way.
Yeah. So rather than like a visceral, when you're saying like the gut or the liver, the stomach that are attached to the spine.
Huge anchors on the spine.
And if they're
pulling it
in, that's going to change the position. Yeah. Same way posture would if you sit.
Yeah. So like your posture just changed.
It's terrible. So like now I'm just really conscious of it.
Bone is not out of place.
No.
But there is a shift in how your body's reacting. So we can't just say, oh yeah, throw out bone out of place model because it's not true. You can't say like that.
Yeah.
But at the same time, you can't say that posture is not affected.
Yeah.
So there's somewhere in there where we need to be better communicating both as professions, but also with patients that go, yeah, look, your bone isn't just falling out over there. I'm going to pop it back in.
Yeah.
But yeah, look, your spine is now not bending well here. So when you go over and pick that thing up or you pick your kids up, can you see that there's a change in how your posture is working? Oh yeah, I see that. Okay, cool. I'm going to use techniques to improve that function.
Right.
Can I then, if someone's 40, can I go and physically make that bone change shape? No. Well, actually I could. It would be very painful because it'd involve a hammer, right? Like,
and a chisel and
so we're not obviously doing that, but we are changing the way that those things function together because there's a bunch of soft tissues around it. The soft tissues relax when we apply that manipulative force to them so that the bone can like settle back into place. Yeah. And those words are terrible, but it makes sense to a patient where they go, oh yeah, my back feels like it can bend now. Yeah. Or my hip, like all my ankle joints, like chiros are not just held to the spine.
Yes.
But yeah, it's hard because if you go back to an x-ray, you look at it, you go, yeah, it is out of place. It is weird.
Yeah.
It's rare to see a straight one. Yeah. Like you would see this, right? Like
100%.
if I see a dead straight spine, I'm like, whoa.
That's weird.
That's weird. We don't see them. So we can't just use x-rays of that. Over the last few years, Medicare has really said no more just x-raying for the sake of it.
Yeah.
Doesn't stop people doing it. Like there are certain chiropractic models that still rely on that model of x-raying, but you'll find that over years to come that'll definitely fall by the wayside and that won't be used.
Yeah.
I don't x-ray very much unless it's warranted.
Yeah.
And when it's warranted, I need it because I need to confirm something that I suspect.
Like a pathology or
like
fracture.
I'm worried there's a fracture. There's a tumor there. Yeah. So, look, put it this way, that it's definitely not used as much as what it used to. There's a time and a place.
Yeah.
There was a period there where it was grossly overused.
And it was a marketing tool.
It definitely is.
Yeah.
It definitely is. Yeah. It's been a marketing tool. It's been overused, unfortunately.
Yeah.
And Medicare lost a lot of money on it, probably. So yeah.
And we'll feed into, the classic model of the high volume chiro, but with I want to recap the cracking side to make that super clear that it's not just something we do for fun and for Instagram and for social media, but it is to essentially modulate the nervous system to be able to reset, create a new form of movement or stimulus.
Yeah.
And then the next stage is super important. So this is where we lose the high volume chiros.
Yeah. Like it's the fastest way and very safe way to be able to take someone's function and change it like that.
Yeah.
Now, does that mean you've solved world peace and the person's now cured? Absolutely not. But what it does do is it opens a window of time for their body to go, I've just received this absolute barrage of information to my spinal cord. So what do I do with that?
Yeah.
Hence rehabilitation, hence exercise, hence, themselves or another practitioner, a physio, an osteo, an exercise physiologist. This is why I like being dual trained in it. It's like, okay, I've just applied this manipulative technique, but now I want you to go and utilize that new amount of information.
Yeah.
Analogy here could be is the person walks in and says, I can't hear very well. Like you right now with earmuffs on.
Yeah.
If I just said, well, how about take off your earmuffs? And the person goes, oh, great, I can hear. Cool. Don't put the earmuffs back on.
Yeah.
Right? That manipulation is, I can't feel my body bending well.
Yeah.
That's not what they say. They come in saying, my back hurts.
My back is sore.
We look at function. I don't care which practitioner you are. That's our job to look at them and go, do you know that you're bending at your back and not your hip joints? Oh, no, I didn't know that.
Yeah.
So we teach them, okay. Now, one thing is there might be a physical limitation in how well they bend. So we go, well, I'm going to not remove, but I'm going to address some of that limitation. I'm going to teach you that if I manipulate this part of your joint, or I do soft tissue work, or I do dry needling, or it doesn't matter what the technique is. I do a technique and suddenly your brain goes, ooh, I have more information now.
Yeah.
And now they can hinge better. So now they can go pick up their grandkids. Now our job is to then train them to go, well, now I want you to do that as opposed to just going back and bending your back at the wrong place and then reinforcing a bad pattern.
Yeah.
So that manipulative tool should set up a bunch of circumstances to improve their function.
Yeah.
If I sit there and I adjust or I manipulate something and it does nothing for either their symptoms and or function, it's like pick another tool.
Yeah. That's not working.
No.
Do something else.
Back to your question, high volume practices, well, I'll just add more of that stimulus.
Right.
I'll just crack more.
Yeah.
To that one day it's going to change it.
Yeah. Okay.
It sounds like the crack. So the crack, I guess, but that manipulation is like a stepping stone to then go into other treatment things, like a movement pattern and that sort of thing. So it's not just getting your back cracked. Oh, I feel so much better and leaving and doing the same thing, because you're going to come back a week or two later and be like, oh, my back's sore again.
Yeah.
Yeah.
We have 160 odd hours to then stuff it up again.
Yeah.
Like that person needs to use that new information. And this is where I say that because the amount of information going into that segment that is manipulated is so afferent, meaning there's a lot of information going in there and then coming out of that area. So it's the same thing with a needle, but it takes longer. And you're going inside the body, where a manipulation is faster. Technically, it could be safer than a needle sometimes, maybe depending on where it's done. And it is safe, but it is a huge amount of information. Massage, same thing. It just takes a lot longer to do. So I think that's probably where, as a tool, it's a fast, effective tool to provide that ability to then go and do something with it. And I think if we don't do something with it, we're kind of hoping and praying that the person's going to come back and we go, is it better? Where if I manipulate it and the person goes, oh, wow. And I go, okay, now show me that in this exercise. I go, now I want you to go home and do that, because you've shown me that what I've done to your body has actually helped you learn something. I say this to almost every patient at some point. I can't undo the patterns that you have in your body. I can't change the way you pick up that glass and put its him out. Meaning I can't get rid of it. I could saw your brain in half and it will not remove those motor patterns. But I can make new ones for you. So if we adjust something, we manipulate, we mobilize, we soft tissue, we do any treatment, and then that person now goes, oh, I feel different. Their brain now has more information to say, I'm going to do this a different way. And then we can then retrain it. Now there's arguments as to how long does that take and how many reps is it. There's books written about it, the whole 10,000 hour rule. And then there's motor learning and all this sort of stuff that come into it.
But I think that's the whole, I guess, purpose of this relearning and retraining, is that we can't undo movement patterns that exist already. We train new ones, but then, you might have a shitty week at work. You might be really stressed. You might have gone and had Macca's on Thursday night and then, had an all-nighter on Thursday, and then Friday comes around and suddenly you do the gym routine that you've done forever. And now suddenly get this weird shoulder pain. Even though you've got new patterns, the more stressed you are and the more outside by a psychosocial model, then you're going to start reverting back to the old movement patterns that you have existed because we can't get rid of them. And that's, I think, getting lost in this high volume world. I'm going to be people are going to hate me for this, but
I'm sure people,
because I have I've got friends that go to chiros once a month. They get their neck cracked. It's 15-minute appointment. It is technically cheaper than we are, but per hour it's not, because it's, $60 for 15 minutes. And they feel good for an hour. And then the same thing goes, but they've been seeing these chiros for 10 years. What is that technically over-servicing, under-servicing? What is happening there?
Yeah, it's a great question. I think we'll argue this forever. In the end of it, no matter what profession we are, we're here to help the person's goals. If the person says, I like coming to you and I spend my 15 minutes and however much money and I feel good, and that's the way it is and that's my goal, it's like, well, the practitioner's not doing anything wrong. They're also not helping the person. So it's kind of like they're just on a stalemate going, cool.
The ethics is hard there. The morals are hard there. That's.
Now, you could say the exact same thing for massage. There's a lot of people that go and get a massage all the time. And I think massage is brilliant. I think it's great. But they're stuck in this model where no one's willing to put down the money and time to research it and actually find out what's going on. Because they just go, well, it helps their biopsychosocial model. It helps their thoughts and their feelings and their depression.
And nervous system.
But how much does it actually change physicality? Well, no one's researching that. So if now someone comes in and says, well, my goal is to get back to pick up my grandkids. If you just go into that same practice and the person just manipulates the one segment over and over and over again and never addresses the fact that this person now needs to pick up the grandkids, it's not happening, but I promise you one day it'll get better, then that's over-servicing and that's not treating the patient. So I think it comes back to what does the patient want and need? Because I know lots of people that go to any other profession and get the same thing over and over and over again. There's lots of people that go to their GP, and I'm not throwing GPs under the bus, so I don't do that. But they just go and get their medication for their problem. And I'm sitting there going, you could exercise and help this.
It's too hard.
It's too hard. I might go, well, that's the same problem as someone just going to a chiro or a physio or an osteo and going, I'm just going to rub this away and then I'll see you next week and next week and next week. If someone comes to me and says, I want to come and see you and I'm going to see you, like, I'm going to invest everything in you, but they say, I want this goal and this goal and this goal and this goal. It's like, that's amazing because we go, I'm going to improve your life quality. Now that looks like on paper, like you see this person heaps, but it's like, yeah, but this person now went from not being able to walk to now being out of the gym 5 days a week, and they've lost 10 kilos. And now they're training for a marathon. It's like, well, that person's hit a lot of goals.
Yeah.
That was worth it to them. They'd spend their whole income if they could trying to get to that.
Yeah.
So it all bases on the goal.
It's all individual.
I can't speak for any other therapist that just runs a model. I think.
Did you ever work in a high volume clinic?
No, I didn't. I worked in a very chirocentric clinic before. But it was still back to what does the patient need and want. They were shorter appointments, but at the same time, I learned to be very efficient with my time and go, I need this, this, and this done. Yeah. And I was still an exercise physiologist, so I would get those people in and go, hey, there's a kettlebell over here. Let's go train with that. So yeah, I can't speak for other people that it's like, you're doing the wrong thing. Yeah. It's back to the patient. And patients know they come here and they go, all right, we say to them, what's your goal? What do you need out of this? Like, we need to get that. And if we're not the right person, then we might refer on to the other practitioner that maybe has a different outlook or a different theory or a different
background.
Yeah. And like the amount of times that people come in and go, oh, I'm here to see you as a chiropractor because physio doesn't work for me. Yeah. And I hear that a lot, and you would probably hear the same thing. But
I don't like chiro. It doesn't work.
It's funny when people come to me and they go, I don't like chiros. I go, oh. You don't know that I'm
interesting. Got some fun news.
And then they go, and like, I mean, I had someone literally this week, they said, oh, this is the best physio appointment I've ever had. And I'm going, that's cool. I'm actually a chiropractor and exercise physiologist. They go, oh, I'm like, no, that's cool. Like,
but I think that's why the movement therapy works, because
it doesn't matter.
We're not our profession.
No, we're not fighting for the patient.
Exactly.
We're not fighting for our professions. We're fighting for the patient. Yeah. We want to do the best for them. Yeah. I have so many people say, I didn't even know what you are. Like, okay, well, because half of my schooling was osteo techniques. Yeah. I've learned from different countries around the world where it didn't matter whether you're a chirophysio osteo. Yeah. You're doing the best thing that you know you could do for the patient. Yeah. I don't care what technique it does in a day. Most patients will get some sort of chiro technique, some sort of osteo, some sort of physio technique, all in one. Yeah. Doesn't matter. Yeah.
As long as it improves the outcome. But if there is an outcome, improve it.
And the patient's goal goes, yes, I'm achieved. And the patient goes, thank you, I'm better. Yeah. Or I now need to work to this.
Yeah. 100%. Yeah. Just quickly to finish off, I know you've got to now go back to treating. Yeah. But Zoe brought it up before, which I wanted to address on, but the babies. Yeah. Because we hear a lot of that. We see a lot of it in social media. Yeah. And a lot of stigma through chiropractic comes from the fact that we are, adjusting, or you are adjusting babies. Yeah. And, you shouldn't do that. What's the point? They're growing. There's no use to that. Yeah. What's the use of?
First problem there is people put on social media. Yeah. So number one, they've already broken the law of putting non-consensual video online. So that's dumb. Yeah. Stupid. And there's been very, very smart practitioners, not just chiros, but they've put information online of a minor. Yeah. Even if the parent consented, I think, don't do it. It's dumb. So number one, there's that. Number two, it's at that point, the kid has no consent. It's the parents to say, I need you to treat it. Now, in a medical model, that's the same thing. If kid's in hospital and has to have a surgery done, it's like the parents say yes. Yeah. So there are a time and a place where a kid needs to be treated. Yes. Should there be a flat out kid should not be treated? No, they shouldn't. Their kids need to be treated. Does that mean it has to be manipulation? No. I think that's the problem here is you're manipulating something where like you've said, the joints are now not formed. Yeah. There's a lot of cartilage still present. The soft tissues are pliable. They don't necessarily manipulation. There's a lot of times where you just pick a baby up and you hear, so they move all over the time. So I'm not going to say that, a cracking noise in a baby is the end of the world. Like that's not. I think the best form of baby treatment has come from the Prague school, where they have literally studied how we function as humans based off observing them. And they treat developmentally disabled or, cognitively disabled or some sort of maturation problem in a baby. And they treat them all the time.
So it's like cerebral palsy.
Exactly.
Like these
some sort
central
of
nerve system issues. Yeah.
And some of it looks really frightening to a bystander. So they would look at it and go, oh my goodness, that's terrible. The baby's crying. Yeah. But then that baby has improved function based off tests that the average layperson have no idea. Yeah. So I remember being at uni and they showed a pediatric specialist doing stuff to a baby. I'm sitting there going, oh yeah, they're doing this test, this test. Yeah, right. Like based off my knowledge from DNS. Yeah. And everyone's going, oh, that's disgusting. That's horrible. I'm like, why? We went, well, look what's happening. I'm like, yeah, they're just doing a test. Yeah. And they're like, what? I'm like, yeah, that's a functional test to see if a baby's developing right.
Yeah.
Yeah.
These chiros had no idea that this was a normal test to do with a baby.
Yeah.
So at that point, people would have gone, oh my goodness, get away. That's horrible. But it's what's your perspective?
And same thing for media, social media. Like lay people have no idea what they're doing.
Yeah, I think it's hard when you open Instagram and you see a baby getting the back cracked and the baby obviously has no idea what's going on.
And it's crying.
So they start crying and they're very distressed and you go, oh, that's pretty full on to do to a baby. But I guess if you don't know the background of it, or, I mean, at the same time, as you said, it probably shouldn't be on social media anyway. But,
like most of this stuff.
Yeah, exactly. Just keep it in the clinic.
Yeah, I think it sounds like there's definitely a reason and, like benefit to it.
Yeah.
But just, time and place and also the reasoning and rationale behind it.
Exactly. Yeah.
As well.
And it doesn't necessarily have to be manipulation. Like there's a lot of babies where if you just put them down and you put their body in a place that it's meant to be, meaning there's support points on the body that should be happening and it doesn't happen. It could be that they've got colic and their belly's like this. And then you give them support and they just go, oh.
Yeah. And they learn that.
And they fart.
Yeah.
And then mum goes, oh, that's amazing.
Yeah.
Like that doesn't have to be, yeah.
Yeah.
Now it may be, I don't know.
Yeah.
Like I've worked with people who have been trained in pediatric chiropractic. I've trained under as I said, the Prague school where they are pediatric specialists and they use manual therapy on these kids, but they're not doing,
yeah,
they're doing them.
The same with physios. Yeah. There are pediatric physios out there that do the same thing. Just we don't
it's not put on social
adjust them and we don't put them on social media. But a lot of the disabilities and a lot of that movement developmental disorders, that's where we come in and start going, well, let's improve something that is what we know is dysfunctional because we've researched it through the developmental sequence.
Yeah, and the key point there is you've done some form of testing.
Exactly.
That
the assessments there.
In a healthy, maturing baby, this is what should happen.
Yeah.
And if that's not happening, there is potential serious side effects down the road.
And for that, it's not putting the baby back into alignment. It's going, let's improve the function of this child.
Yeah,
which is the same for, adults as well.
Yeah. We could go on about this.
I know. Yeah. we better wrap it up, but we will keep it for part 2. I think we're going to continue this, next week as well. So Darv, thanks so much for your time.
Pleasure.
And we'll keep going next week.
Hopefully I didn't stress off too many chiros or physio.
We apologise for all the chiros out there and physios, but I think it's really important conversations to have and why we work so closely with all 3 professions, well 4 including EP as well. Yeah. So it's a really good to get that information out there and start becoming mainstream and start just breaking down the stigma of everything.
Great.
Awesome. Thanks, Darv.
Thank you.